Thank you, Dr. Chitra Ramamurthy, to have asked me to participate in this course. I would like to thank Dr. Nivedita, who's a cornea person with me, who's helped me to create this. Now, the question is about regression and ectasia because this danger sign in between is quite obvious because the whole management and the treatment is going to change. So, what happens really in regression is a tendency for an eye to return some part of the original refraction. So, if you have treated -5, of course, it's not going to become -5 again, but patient may get a -1, 1.5 again. So despite of advances in laser applications and the precision and the mode of corneal flap removal, regression in refractive error is still a known possibility and we have to tell our patients about it. But over the number of years, recently, the regression amount has really dropped. So how much is our retreatment rate for regression is hardly less than 0.66%. Some documentation has done this. So modern lasers, newer updates of software, and data of so many years of LASIK, regression really is not a fear that we should have today. But how will we differentiate the two? So now the pathophysiology, a lot of discussion on epithelial thickness was documented. Sir, Dr. Praveen Krishnan and Dr. Gaurav both said something, and which is also going to be concluded in my talk that yes, this is how we are looking at it. It has been noted that epithelial compensation is a major cause of optical regression after refractive surgery. So these patients will have an epithelial thickening. Corneal stroma can also undergo morphological changes. We know that they do undergo changes over the number of years and in response to excimer laser, which can lead to refractive regression. So the basic pathophysiology is, of course, the regulation of the limbal stem cells, proliferation, increase in cyclosidine, and a concentration necessary precursor for refractive regression. Now, this chart is very commonly shown in most of the presentations, but if there is an epithelial debridement, either we do a surface treatment or we do a LASIK where there is a whole rim where the amount of epithelial cells are affected, then there is keratocytes proliferation, different factors come into play, haze producing ECMs come into secretion. This leads to further epithelial hyperplasia and this leads to regression. So this is a whole cycle that happens throughout the regression. I feel whenever we conclude whether it's regression or not, mapping the epithelium is very crucial. So now, in fact, sometime back we have started, whether we do LASIK or surface or whatever procedure, SMILE, we do epithelial thickness mapping for every patient as a protocol. And if you feel, then we are also trying to make a difference whether over 1 month and over 3 months, is there any change happening in normal LASIK patients or not? And that's the reason why you can see that there's a thickness that is there in the epithelium, which is in the center, is known that this will go into regression. As rightly pointed out by Dr. Gaurav, if the patient has got hyperopic LASIK, you may see thickening on the periphery, and this is where exactly the treatment had happened. Optical zone, if a small optical zone is there, it has known that it will cause higher chances of regression. Flap thickness, so if you have thick flap, like olden times we used to have 130 and 160, also leads to higher chances of regression. Older age group is associated with regression. And of course, pregnancy and lactation in women is known to have a factor that affects regression. As rightly pointed out by Dr. Praveen Krishnan, that if we do not use mitomycin, it will cause epithelial thickness and will cause some amount of regression. So now we all use mitomycin and a refractive correction about more than -5. But this is not seen in the new lasers and the new softwares which is there. And all of us don't decide to have a small optical zone. All of us have large optical zones depending on the size of the pupil. So management of regression, yes, it's very clear that if it's a good healthy flap, adequate residual thickness, and OCT-based assessment on the whole flap that was made. If you have an online pachy, we can know the thickness of the flap during the procedure. We have an online pachymeter, so we make a note of the thickness of the flap every time every surgery is done. And if all these parameters are good, the patient can go into a relift. But if it is a decentered flap, an irregular flap, a surface ablation, or a wavefront guided or a topo guided LASIK can be done. Coming to ectasia, corneal ectasia was first documented in 1998 by Professor Theo Seiler, and it's characterized by progression, steepening, and thinning of the cornea accompanied by topographic and tomographic changes. There is increase in myopia, astigmatism can be regular, irregular, decrease, and in uncorrected, best corrected visual acuity may also happen. And patient often complains of glare and halo. So despite we have done all the risk factors, development of ectasia, we have done all the care, patient can still develop ectasia and the picture may look like this. So a thorough pre-op examination is of course necessary. We know that a stable refraction, corneal topography, family history of keratoconus, many times we don't look at that and ocular hysteresis has to be looked at. Now this patient operated many years back, presented to us with diminished vision in the right eye and the left eye, 660 and 612, and you can see that there is a thinning right in the center, which presented with ectasia. The patient was then underwent cross-linking with Intacs, and the patient's vision improved to 6/12 in that eye. So the left eye, you can see a posterior float, which went ahead quite a bit. So there in ectasia, then we have ectasia risk score system, and this was by Randleman and his group. There are different ways of looking at it. So you have to look at the residual stromal bed. We look at the age, the central corneal thickness, and there are points at 4, 3, 2, 1, 0. So if all the topography and everything is normal with the residual bed, nowadays we all have the RST more than 300. I think this is the normal protocol followed by all of us. And if we do overlook any of these risk factors, then there is a chance that patients will develop haze. So if you are in a score between 0 and 2, there's a low risk. But if the score is 4, then there's a high risk that the patient will develop ectasia. So the new tool, of course, is the PTA. All of us also follow this, the flap thickness plus ablation depth divided by central corneal thickness. But I believe there was a huge study in Korea. Some of you might know about this, where in one eye they followed the PTA, in the other eye they did not follow. And I think the study was almost 12,000 eyes. And they found no statistical difference. I don't know what the panel would like to say after I finish my talk, but I'm still following PTA in my protocol as routine for all the patients. The main reason being legality. So PTA we know has to be 4-0 and we don't cross that line, and the flap thickness will, and more the depth of, more the thicker the flap and more the ablation depth will also lead to ectasia. So the basic pathophysiology here is, of course, thicker flaps, deeper ablations, leaving thinner RSTs can lead to this. Epithelial hyperplasia, Bowman's layer breaks can lead to ectatic regions, and both intralamellar and subsequent interfibrillary slippage contribute to chronic biomechanical failure and ectasia after the surgery. There is thinning and loss of rigidity, stress-bearing regions of the stroma, thinning of the collagen lamellae, and loss of total number of lamellae can lead to basic management. Of course, if there is ectasia, one can go ahead and do intacs if the cone is decentered, and go ahead and do cross-linking. But cross-linking is a necessity. I don't think we should wait. So if patients with LASIK treatment have developed ectasia, they have to be treated. Normally in keratoconus, we wait because we know statistically that 22% of keratoconus do not progress. But this patients should not be wait, and we should go ahead and do the treatment. Invasive management, of course, the worst case scenario, if the cornea becomes really, really thin, PK, which is not done anymore, but now DALC would be another good option. So the take-home message here would be, in regression, the refraction post-refractive remains quite stable, so the patient may get some percentage of the number back. Increase in epithelial thickness, increase in corneal thickness and mapiment. So you have to check the pre-op data and the post-op data. And normal pattern is seen on the topography. In ectasia, progressive increase of refraction may be cylindrical in different axes, irregular astigmatism, epithelial thinning noted on the tip of the cone, corneal thinning noted on pachymetry and the posterior float, and abnormal shape, asymmetry, bow tie, inferior superior steepening. All of this can lead a difference between ectasia. Treatment, of course, is glasses, contact lenses, lasers, and enhancement procedures. As far as regression goes, here it can be intercorneal rings, cross-linking, DAL or PK. So these are the references, and I would like to thank Dr. Chitra to have asked me to participate in the course. Thank you very much.
Thank you.